A large number of children and, in fact, adults are being afflicted with this group of disorders called primary immune deficiency diseases. Let me break this word or break this phrase into two important words. One is primary and second is immune deficiency. Immune deficiency would mean somebody who does not have an efficient immune system. Now, to make it simple, I can compare this with the army that protects us from our enemy. In the very same way, our body has got an army of white blood cells that protects us consistently and constantly from our enemies. Our enemies being viruses, bacteria, and several other pathogens. And the army here consists of white blood cells and several kinds of proteins that these white blood cells produce, including chemicals, cytokines, and immunoglobulins. However, unfortunately, a few people are born with without an efficient immune system, and that is because of a genetic defect that leads to a deficient immune system. We call it the primary immune deficiency. There is also a term called secondary immune deficiency, wherein these patients have immune deficiency not because of a genetic defect, but because of something that has been acquired. For example, an infection like the human immunodeficiency virus or HIV can cause a secondary immune deficiency. Drugs like uh, corticosteroids or steroids can definitely cause immune deficiency, but that is what we call a secondary immune deficiency. However, there are two more important functions to our immune system. One is an efficient immune system constantly kills cancer cells in our body. There are mutations that are happening constantly in our cells, and these mutated cells can sometimes turn into cancer. But a healthy immune system will efficiently delete these cancer cells. The third important function of our immune system is to maintain self tolerance. It means our immune system would never attack our own tissues, it will only attack a foreign invader. So there are three functions: fight against infections, protect against cancers, and have a self tolerance. Now, when a patient or when a person has an immune deficiency, a genetic immune deficiency, he would not only be predisposed to infections, but he would be predisposed to increased risk of cancers and an increased risk of autoimmunity, a condition wherein our immune system attacks our own body. And that is why the right term or the new term for primary immune deficiency is inborn errors of immunity. The medical scientific societies now call these group of diseases inborn errors of immunity. When I say inborn, it again means genetic, and errors of immunity, as you can understand, these are defects in the immune system that predispose individuals to infections, malignancies, and autoimmunity. So, one of the important questions that I'm often asked is, are these diseases very common? Are these diseases rare? Or should we really talk about these diseases? Now, to give you a perspective, let me tell you that this is not a single disease. The group of diseases that I'm talking about is not a single disease, it's a collection of diseases. And the latest classification that was proposed last year said that there are close to 485 diseases under this umbrella. Now, let me tell you, as I speak, the number keeps expanding, and I will not be surprised that today the number has crossed 500. What do I mean by this? Well, way back, say if you go 2 decades ago, 20 years back, there were only 50 diseases that were described under this umbrella of primary immune deficiency. 5 years back, this number crossed 200, and now this number has almost touched 500. Now, why is this happening? This is because of rapid advances in medical science and molecular genetics that new genetic diseases are being discovered. And that is why newer diseases are being described, and patients who did not have an appropriate diagnosis, say 10 years ago, today are being diagnosed because of better availability of diagnostic facilities. Well, what does it mean to the population out there? How common is it in the population? These diseases as a group are very, very common, and 1 in 1,000 individuals are said to be affected with one or the other primary immune deficiency. 1 in 1,000 is not a small number. What does it mean to our country? It simply means that more than 1 million people are affected in India. That's a huge number. But what is the actual number that is being diagnosed? At the moment, as I speak, a few hundred patients or a couple of thousand patients must have been diagnosed to have immune deficiency. It simply means that several thousands of patients are not being diagnosed and they keep suffering for months and years. And some of these diseases are so severe that these children die at a very young age without getting diagnosed. And that is why there is an urgent need to raise awareness regarding these diseases in the society. Yeah. To arrive at a diagnosis of an immune deficiency, it is very essential that medical practitioners out there, especially pediatricians and physicians, are aware about these diseases. Now, if you ask me when should a pediatrician think of an immune deficiency or when should a physician think of an immune deficiency, I'll give you simple clues. One is infections. Now, as pediatricians, children often come to them with recurrent infections, maybe repeated viral infections. And if children are doing well apart from viral infections, I would suggest you should not investigate. However, if children come to you with severe, persistent, unusual, recurrent infections, severe infections that need multiple hospitalizations, like severe pneumonia, chest infections, ear discharge, recurrent episodes of diarrhea, unusual skin infections, and if children are not growing well, what we call failure to thrive, that means they are not gaining height and weight as per their age, that is where pediatricians should start thinking of an immune deficiency. It is also essential to think of these group of diseases if children come to you with cancers along with infections, or if children develop autoimmune diseases at a very young age. Usually autoimmune diseases in children start at a later age, but having autoimmunity before the age of 5 is very unusual, and that is another place where pediatricians must think of an immune deficiency. Now, these diseases are not restricted only to children. Even adults can suffer with an immune deficiency. The most common immune deficiency in the adult population is the common variable immune deficiency. And adult physicians who deal with these patients can suspect this disease when they see a patient coming to back with chest infections. Often these patients would go to pulmonologists and they undergo bronchoscopies and several investigations without getting an appropriate diagnosis. If patients come with chronic diarrhea, loose motions that just don't stop, months together of diarrhea, weight loss, in such situations, the gastroenterologist may be dealing with these conditions. They must investigate. Sometimes these patients come with cytopenias. That means the blood counts are very low. The hemoglobin, the platelet count, the white cell counts are very low. The hematologist must be dealing with these conditions. Again, there is a need to suspect these diseases in this setting. As far as the parents or as far as the patients are concerned, I think for them it is very essential to make a note of all these symptoms, because when they go back to physicians or their pediatricians, they would be often prescribed antibiotics. But then if they can make a symptom diary, and when they report to their physicians, present the symptom diary and tell them that how they have been suffering again and again with repeated problems, it is then when the pediatrician will make a note of the symptomatology and start working you up for an immune deficiency. Because right now, I would say several cities, almost all the metropolitan cities will have investigations available for evaluation of these group of diseases. So the word frequent, if you go back and refer to the Jeffrey Model Foundation, what you say, JMF, warning signs of immune deficiency, they would state if there are 4 episodes of ear discharge in a patient within a year, or more than 2 episodes of pneumonia in a patient within a year, several episodes of diarrhea, or oral candidiasis beyond the age of 1. So these are few numbers that this foundation has laid down to bring about an awareness. But let me tell you, these numbers are very arbitrary. For a physician or a pediatrician who regularly deals with patients, he would know that this particular patient is coming too often than usual. So unusual here would mean unusual number, wherein the pneumonia is happening again and again. It could be unusual severity, a patient with an infection landing up in an ICU, or it could be an unusual pathogen. So when you have infection, we look for what microbe is causing the problem. There are some common microbes, there are unusual pathogens like fungus. So it may be the first episode of fungal pneumonia, but it will need investigation. So and another important aspect, very very important aspect, is the family history here, because these are genetic diseases. So often we see that the first child was suffering with a disease. They could not arrive at a diagnosis. The child expired. He could not make it. And the second child is brought to us. And just because the family history was positive, we were right on the toes that we were like, we have to investigate. And that is where we got the diagnosis quite early. So a good family history does help in this situation. So, before I talk about tests, let me reiterate this fact that a very good clinical history is essential to make a diagnosis of an immune deficiency, because often these patients undergo several tests because they are suffering for many, many months and years. They have a bundle of investigations that they often come to us with, and still they don't have a diagnosis. So, before investigations, it is a good clinical history as to what is the problem of the patient. Where are these infections? Is it in the lungs? Is it diarrhea? Is it skin infections? So what are the kind of infections? What are the kind of pathogens that this patient is getting infected with? The other question that I was just talking about is a good family history. Having a very detailed family history sometimes not only tells us there is a genetic problem, but what is the pattern of inheritance? Even that we are able to make out. Now, once we have suspicion, we can start investigations. Now, let me tell you simple investigation. Sometimes we get clues from very, very simple investigations. A hemogram, or what we say the complete blood count, is something that most patients would get done when they are unwell. But in a young infant, if the complete blood count is showing very low lymphocyte count, lymphocyte is a type of WBC, white blood cell. If the lymphocytes count is very, very low, below 3000, we suspect severe combined immune deficiency. This is a very, very serious immune deficiency. If the neutrophil count, which is another type of WBC, is very low, we think of severe congenital neutropenia. If the WBC count is very high, say sometimes way above 1 lakh, we talk about leukocyte adhesion deficiency. Sometimes boys come to us with very low platelet counts, thrombocytopenia, and we suspect Wiskott-Aldrich syndrome. So sometimes it is basically done, the routinely done investigations give us clue to pick up the diagnosis. However, when we suspect a disease, we carry out a group of investigations called immunological tests. Now, this is essentially to check for the immunity of a patient. So we do serum immunoglobulins. So these immunoglobulins are fighter antibodies that we all have in our body. And if somebody has very low immunoglobulins, we know he's got an immune deficiency. We also check for different types of white blood cells, the lymphocyte subsets. We do some specialized testing like the dihydrorhodamine dye test based on our suspicion. So this is the second level of investigation where we do an immunological investigation or immunological screen. And whenever our suspicion is very high, to confirm the diagnosis, we do something called a genetic test, which is also a blood-based test. So often 1 to 2 ml of blood is given to a genetic lab, and they can perform something called an exome sequencing and look for the exact gene defect which has caused this problem. So this is how we can arrive at a diagnosis in most patients. There are two things here. One is the availability of a genetic test, and second thing is the advancement in molecular diagnostics. Now let me take up the second part first. As I described before, previously only a handful of diseases had been described by medical science. Now as medical genetics advanced, newer genes were described which were now known to cause immune deficiency. So that is how the list of immune deficiency has expanded, and this is thanks to research in molecular genetics. However, what has significantly changed for us as clinicians in the last decade is easy availability and accessibility to the genetic testing. A decade ago, there was hardly any private lab or a commercial lab that was doing a genetic test in India. Now we have scores of labs which are offering genetic tests. Also, because of the competition in the ecosystem, the pricing of these genetic tests has significantly gone down. And this has really helped us as clinicians to order these tests and so that we can make a diagnosis in majority of our patients. So definitely things have changed in the last 5 to 8 years. how do we really make sure that every patient out there gets a timely diagnosis? That now that this needs a multi-pronged approach. You cannot have a single approach here. One would be to make the physicians, the pediatricians, the practitioners make aware of these conditions. Now, what do we do to make them aware? We conduct regular CMEs, continued medical education programs, wherein we address a small group of people, say 30 to 50 pediatricians, and tell them about these diseases and how they can all diagnose such conditions in their practice. Also, in large medical conferences, we talk about these diseases, and that helps. But this will not be the only way. In fact, to add to this, I have published a very small book called Primary Immune Deficiencies Made Simple. This is a 150-page handbook which is available online, say on Amazon. And several pediatricians and physicians have referred to this book and have come back telling that this book, a small handbook, has really helped them diagnose these conditions. So sometimes having small handbooks helps busy practitioners to understand the concepts and make the diagnosis. Now, talking at the society front, we need to talk more about these diseases on platforms like these that you are spreading awareness. Also, media is going to play such an important role. Either it may be print media or virtual media. More and more we talk about these diseases, more and more people are aware about these conditions. It helps. And then finally, it is the patient organizations. We do have patient organizations on immunodeficiencies who themselves also try to raise awareness in the community. So I think having a multi-pronged approach is the way forward, wherein we can ensure most patients get timely diagnosis. Yeah, definitely not all 500 diseases have the same severity. Some of them are very severe. To name a few: severe combined immune deficiency, SCID, uh, severe forms of leukocyte adhesion deficiency, severe congenital neutropenia. So these are certain diseases which are so severe that if we pediatricians don't pick up them early, most patients die in the first 1 year or maximum 2 years of life. So these are universally fatal. SCID, the severe combined immune deficiency, is said to be a medical emergency because unless diagnosed and treated, 100% of patients die within the first 2 years. So those are the most severe immune deficiencies. Now, then the second subgroup, I would put it as, say, moderate kind of immune deficiencies. In some sense, because they present a bit later, these children start having problems usually beyond 2 or 3 years of age. They come to us with repeated chest infections and ear infections. The classical example here is X-linked A gamma globulinemia. And here these patients don't produce immunoglobulins. It is, it is a protein that fights infections. And so we have to treat these patients by giving them back immunoglobulin injections. And then there are patients called CVID, the disease I was talking to you before, as common variable immunodeficiency. These patients often come in the second and third decade of their lives. So it is often adult patients who come to us with infections and autoimmunity, and they often suffer for years. They don't die, but they keep suffering for several years until a diagnosis is really established. And then there is a chunk of mild immune deficiencies wherein people keep suffering but get better with antibiotics. So, yes, this is a spectrum of diseases, and not all of them are very severe. I am a pediatric immunologist, so I am a pediatrician. So, most often I would end up seeing children in my practice, though I do see adult patients because there is nobody who really practices adult immunology. At least in Bangalore, or I think most places, we don't have adult immunologists. Most of them are rheumatologists who deal with autoimmune diseases and they don't deal with immune deficiencies. Now, let me give you a perspective. In India, majority of the patients that are getting diagnosed are children. It is just because adults are not getting diagnosed. It does not mean adults don't suffer. There are like thousands and thousands of patients in India who are not getting diagnosed. They, I think, are with the pulmonologist or the gastroenterologist or with the hematologist and getting treated without getting a diagnosis. Now, if you go to the Western literature, in the last decade, their literature says now close to 40% or sometimes close to 50% of their patients are adults. That is not the scenario in India. So, what it means is, as awareness increases, as adult physicians start diagnosing, more and more adults will start getting diagnosed with immune deficiency. I think the viewers by now would have understood that since it is not one disease that I'm talking about, there cannot be a universal treatment or the same treatment to all patients. So it would not it would not be appropriate to offer the same treatment to every patient. So naturally, it is very, very important to arrive at a diagnosis. Now, there is a subgroup of immune deficiencies which are milder ones. For example, the IgG subclass deficiencies, wherein often giving them long-term antibiotic prophylaxis helps these patients. But this is a small subgroup. Now, there is another group of disorders. These are B cell group of disorders. The examples being X-linked agammaglobulinemia, the common variable immune deficiency. These patients need immunoglobulin substitution. They don't have immunoglobulins in their body, so we give them immunoglobulins intravenously every month. The only challenge is we need to give them every month for the whole life. So this is monthly immunoglobulin substitution that is being done for a subgroup of these patients. Now, the most serious immune deficiencies like the SCID, the leukocyte adhesion deficiency, the chronic granulomatous disease, these patients need a bone marrow transplant. Now, bone marrow is the source of all blood cells in our body, including the white blood cells. And if you can replace the bone marrow with a healthier bone marrow from a donor, then you can cure these patients. So, bone marrow transplant can be curative in a majority of these conditions. To perform a bone marrow transplant, I think the most crucial factor is to get a match. And we always look for something called a 10 by 10 HLA matched donor. Now, the first source for us to look for the donor is within the family. So, the siblings of the child who is affected, if the siblings are unaffected, we do an HLA typing, and there is a good chance of picking up a donor here. I would say theoretically 25% chance of having a full match 10 by 10 donor within the family. Now, if we don't have a donor in the siblings, we look at the parents, the father and the mother. Often these parents are half match, what we call the haplo match, but occasionally they can be full match and we can choose them as the donor. Now, the final situation obviously is to go out to a registry. Now, if you need a blood transfusion, you go to a blood bank, isn't it? In the same way, there are registries called bone marrow registries, and we approach those registries and apply for the registries and ask them if they have a donor that matches the HLA of our patient. Since the registry size of Indian registry at present is smaller, it is often difficult to get a donor, I would say. The success rate could be somewhere between 10 to 20%. But then as awareness increases, because we all can become donors and there is no harm or no side effect. So as the pool size of the donors increases, the chances that we'll get a full match donor from the registry will also go up. So once the diagnosis is established, it would come as sometimes a big relief to the families because they stop going from doctors to doctors and stop doing medical shopping. However, it will also come as a shock to certain families where the disease is very, very severe. So the kind of counseling that we do will also depend on the type of the disease. For example, if a patient has got a serious immune deficiency, like severe combined immune deficiency, we don't have much time. So this has to be treated as an emergency. So we talk to the family in detail, tell them what is this condition, why has this child got this condition, and what is the kind of care that we need to offer. Obviously, we need to take care of their infections. We take care of their nutrition. Often these children are completely malnourished, and so we involve nutrition specialists and build a nutrition. We need to start them often on immunoglobulin substitution, and we prepare them for a bone marrow transplant. This is what we do for the severe immune deficiencies. Now, for the milder immune deficiencies, we again sit with them, explain the disease to them in detail, tell them that this is a lifelong commitment that the families need to have with us, and they need to take regular medications and also avoid certain things. For example, even we need to give them a detailed advice on vaccines as to which vaccines they can take, which vaccines they should not take. Just to complete this topic, I would say in severe immune deficiencies, often live vaccines are contraindicated, whereas killed vaccines may not be helpful. However, in certain immune deficiencies, for example, in subclass deficiencies, IgG subclass deficiencies, we provide them vaccinations. We tell them they must take pneumococcal vaccine. So even vaccination is a very, very important advice to these patients. It is important to remember that the oral polio vaccine that we give for the prevention of polio is actually contraindicated in patients with severe immune deficiencies like SCID, because occasionally it can result in paralytic polio. So this is the advice that we give to our patients. We talk to our patients in great detail about genetics and do genetic counseling, and sometimes we involve genetic counselors, because these are genetic diseases and they are likely to recur in the next pregnancy in the given family. And the recurrence rate can vary anywhere between 25 to 50%. And this is a very important topic of discussion, because we can treat the index patient, but it is essential to help the family as a whole so that they don't get up or land up in a similar situation in the next pregnancy. So, getting a genetic diagnosis is very crucial. Once we get a genetic diagnosis, we can prevent the occurrence of such a disease in the next pregnancy by performing antenatal tests, something like the chorionic villus sampling, CVS, or amniocentesis. And fetal medicine specialists help us prevent, basically diagnose these conditions in the subsequent pregnancies. I need to tell you that there are different kinds of genetic diseases. Now, there is something called autosomal recessive diseases, which are common in setups where there are consanguineous marriages. We know in India, a lot of endogamous marriages happen within communities, and in several societies, people marry close relatives, wherein you have what is known as consanguinity. In these group of patients, we get autosomal recessive diseases, and sometimes multiple family members get affected. The second group of disorders are autosomal dominant disorders, wherein sometimes we see the child and one of the parent is affected. And the third group of disorders is the X-linked disorders, wherein it is usually the boys in the families are affected. So the boy is affected, the mother is a carrier, and maternal uncles, that means the mother's brothers, are affected. So based on the pattern of inheritance, we do suggest testing for parents and extended family members. And sometimes we end up picking up several patients in a single family and extended family, and then we offer treatment. So we do offer testing to families and extended families, but it would depend on the type of inheritance that we are talking about. We often face resistance. Usually, it is not the immediate family. The parents are often willing to get testing done because they want care for their child. But when it comes to extended families, I would say, don't succeed always, because most of the time, the extended family, if they don't have much symptoms, or if they are polysymptomatic, or if they are being treated for other diseases, then they are not interested to come and talk to us, because until we talk to them and counsel them and make them understand why we want to test them, it is difficult. So we do face resistance when it comes to extended families. In the Western world, you have something called a universal newborn screening programs. For example, in the US and most of the European world, they routinely test for severe combined immune deficiency right at birth. This is a universal newborn screening program. In India, we don't offer such programs. So maybe the step forward for us is to look at offering a newborn screening program to our children. Yeah, the treatment definitely will come with a cost here. I would again split it here with the milder varieties and the severe varieties. As you talk about the severe immune deficiencies, we need to go for a bone marrow transplant, and the transplant procedures would be costly. However, in the current day scenario, because of availability of NGOs, because of crowdfunding platforms, because of the rare disease policy of the government, and several, I would say, philanthropists who come up and support these children, in our setup, we have been able to transplant a majority of children. We have usually never failed to transplant a child for financial reasons, though there is a significant financial burden here. Second thing is those patients who need immunoglobulin substitution. Now, the good news is several state governments in India provide monthly free IVIG infusions in government setup, including the state of Karnataka. And through this, I think we are able to support a lot of our patients and give them IVIG injections. Yeah, so for example, if it is the IVIG infusion, then when they meet us, we kind of guide them or direct them to the government organizations with a what you say, a reference letter with a clear diagnosis, and they go and register with the government hospitals where they can get immunoglobulin infusions. As far as the transplant is concerned, we help them raise funds, because several in many situations the state government funds, the prime minister funds, and the crowdfunding platforms, it is as physicians we take up the responsibility and help them raise funds in the such situation. Yeah, I would first like to talk about the don'ts. Since we talk about low immunity, people jump and want to buy immune boosters. They often come and ask us what immune boosters to buy from the market. I would say don't spend on immune boosters. We are only boosting the pockets of these companies who are selling immune boosters. Such immune boosters have no value to my mind in boosting the immunity of these patients. So it is a strict no to buy immune boosters from the market. Well, they should have certain do's. A healthy home based diet is what we advise, a diet which is rich in protein. And obviously, they should cut down the junk and all such kind of food which is unwarranted. For many of our patients, we also give them an advice to use a healthy source of water. Many times we say it's better to have boiled water, wherein they carry it with them and often use that, because water can be a source of infections, and sometimes when patients develop diarrhea, it is quite troublesome for them. So that is why good source of water, home-based healthy diet, high protein diet, and avoiding immune boosters. This is the general diet advice that we give to all our patients. And we definitely need patient support groups. And fortunately, in Bangalore itself, we have a patient support group called PIDPWS. This is Primary Immune Deficiency Patient Welfare Society. And this society has, I would say, supported a lot of patients, because this society is being formed by the families of patients who are suffering, and they kind of support each other. And in several such occasions wherein, as medical practitioners, we are not able to answer them, practical solutions and answers may be got, and the kind of social support they need, that can be offered by this society. Also, these societies along with us work to get government to support such causes. For example, getting funding for IVAG, getting funding for BMT. To raise the voice, we need a society. So these patient support groups obviously are doing a great job, and we constantly work with them to help our patients. I would only conclude saying that these diseases are very common, and more the physicians, pediatricians get aware. I hope our children get diagnosed early and we treat them early. Thank you.